So today's video will be centered on looking at trigger points and their application in today's injury prevention and rehabilitative space. So just to get into a little bit about what trigger points are before we talk about the evidence behind them, they're commonly thought of as tight, restrictive, sometimes painful nodules within a muscle belly. The referral patterns are basically areas that will elicit pain, but not necessarily where the trigger point's located. So, for example, in the trapezius muscle, there could be a trigger point deep in the muscle belly, but you could get referral pain down the arm, out towards the shoulder blade, sometimes up through the neck. That's all I mean by referral pain. So, that out of the way, let's talk about the research behind it. And as far as I know and have read, the U.S. physician who is at the forefront of myofascial trigger point theory is Dr. Janet Travell. Starting as far back as 1950, she's co-authored more than 40 papers on the subject and helped popularize, define, and diagnose myofascial trigger points among the healthcare community. The best information that I've found that chronicles the advances among trigger points is an article called Myofascial Trigger Points, Then and Now, A Historical Scientific Perspective, which I'll put a little bit of on screen, and I'll reference below. Not to get too wordy with the explanation, I'll sum up the findings of this article, in that we still aren't sure about myofascial trigger points and their role in musculoskeletal pain, with data being published that musculoskeletal pain can be acute, chronic, or caused from muscle or fascia, and that myofascial trigger points are central to the diagnosis of it, even though there are such a wide variety of objective findings associated with myofascial trigger points. All shows that we still don't really have a solid grasp on how they form or how to effectively treat it. Old theories for the pathogenesis of myofascial trigger points, or the creation of myofascial trigger points, includes muscle overuse and mechanical difficulties. And while these are not proven or disproven, we can also look to more current research to get a bit more of an idea as to where these come from. Current research has been shown to link myofascial trigger points with a high negative impact on function at both the physical and psychosocial level, which may have something to do with nociception and how pain is actually perceived in the body, which is a topic for another day. But continuing on with the evidence, as far as treatments go, I mentioned before that currently with our tenuous grasp on trigger point theory, there isn't really a widely used one-stop treatment for trigger points. We can see this in all the modalities that healthcare practitioners use, such as massage therapy, cupping, Graston, dry needling, etc. What may work for one person may not work for the next. But all in all, there are many things that need to be researched more, which is difficult because musculoskeletal pain isn't a primary research topic for most medical studies. Muscle pain is often referred to as an orphan science because there's no specific group of research that owns that space. Yet there's a need for more research on it, as musculoskeletal pain is a fast-growing field of interest for a lot of these type of allied healthcare professionals. And current research is lacking, which is actually acknowledged by researchers in many of the studies that I've been reading. And referring back to the article that I referenced above, they mention that there are many things we don't know, such as what's the pathophysiology of musculoskeletal pain, what's the role of trigger points in the genesis of pain, is the resolution of trigger points required for a positive clinical response, what's the mechanism by which painful states begin, evolve, and then persist, how do tender nodules progress to a myofascial pain syndrome, and many other questions which are still left unanswered. So where does this leave us treatment-wise? Anecdotally, as a massage therapist, I can say that I've provided treatments for trigger points in the past and I've gotten mixed results. As such, I've delved into the root of the cause of pain through research to develop a more thorough understanding of the origins of pain and to try and become more aware of why we experience certain mechanisms at play. Let's use a classic example of neck and shoulder pain, which is pretty commonly it's a commonly treated area in massage therapy space, and including any other healthcare practitioners such as physio or chiro. There are many referral patterns that could lead you to believe there could be a trigger point in the neck or shoulder area. Just to name a few examples from the book Trail Guide to the Body's quick reference to trigger point book. The muscles known as the trapezius, the supraspinatus, the rhomboid major and rhomboid minor, levator scapula, triceps brachii, splenius cervicis, scalenes, and serratus posterior superior all have overlapping trigger point patterns. So in reference to the subjective pain that someone reports, can we really be sure as to which one contains the trigger point if there are so many overlapping areas that can recreate the same pain? It's also a possibility that trigger points may not be the cause of pain, but from an entirely different pathology, such as nerve compression or entrapment, just to name a couple. One example that I can give is of dermatomes. So dermatomes are defined by Gerald Tortora and Bryan Derrickson in the Anatomy and Physiology book as an area of skin that provides sensory input to the central nervous system via the posterior roots of one pair of spinal nerves or via the trigeminal nerve. These have been mapped throughout the body, pairing an area of skin with a certain nerve root. And if we look at the picture here of dermatomes in the body from Anatomy and Physiology book, we can see that the typical shoulder and neck pain hovers right around the C3, C4 nerve root dermatome area. A study on dermatome mapping called Pain Patterns and the Descriptions in Patients with Radicular Pain, Does the Pain Necessarily Follow a Specific Dermatome, was conducted where researchers took 226 nerve roots in 169 patients and addressed each one according to the dermatome map and found that 60%-ish of pain was not linked to dermatomes. However, if we take the opposite side of the coin there, it also means that 30% of patients did, in fact, have pain aligning with this specific map. Something worth considering, for sure. Issues in the nerve root usually stem from disc bulging or some sort of mechanism involving the spine where the nerves become restricted or pinched. So pretty much everybody's heard of a pinched nerve at some point. And these can cause that radicular symptom, not unlike a trigger point. And this is only one example of many similar scenarios, but for the sake of brevity, I'll just stop at the dermatomes. Just know that there are many things that can recreate pain over a certain area, where pain is only a sensation, it's not necessarily the cause. My point with all this is that while you might experience trigger point-like symptoms, it's always in your best interest to check with a professional in your area to try and find out the root cause before trying to dig into a painful area yourself, such as with a lacrosse ball, or in extreme cases I've seen people digging into desks and chairs just trying to get some relief. So you may want to consult with a professional to try to come up with a solution for what you're currently experiencing. I know personally, where I live in Canada, a trained registered massage therapist, which is what I am, in a regulated province, can do orthopedic assessments and provide home care as well, in addition to massage therapy treatments. Anyways, I hope this was informative, and as always, thanks for listening.